Welcome to A Woman's Outlook. I'm your host, Deborah Hoke. I would like to welcome back Dr. Mupombwa. Hello.
Hi, Deb. How are you?
Thank you for coming back to our studio.
No, thank you for having me. I feel very, very honored that you guys invited me back again. Thank you so much.
Well, we have to explain to our audience, you are a minimally invasive gynecological surgeon who specializes in fibroids.
Correct.
Tell me how you got there.
How I got to fibroids?
Fibroids.
So it's a long journey, but I think the interesting thing is that this month is Fibroid Awareness Month, so it really fits well in terms of trying to promote fibroids out there. So I think I've always been interested in women's health, and growing up in a community where a lot of women are affected by fibroids really spiked my interest in fibroids. And then throughout my training in residence and fellowship, I was always drawn to fibroids. So that's how I ended up getting to fibroids.
What is a fibroid?
So the way that I simplify it to patients is that a fibroid is just a benign growth or benign tumor. By benign tumor means that for the most part, it's not a cancerous tumor, and that tends to grow in the muscle layer of the uterus.
Are there types or different types of fibroids?
Absolutely. So the type of fibroid depends on where it grows on the uterus. If it's closer to the inner line of the uterus, it has a different name. If it's on the outside of the uterus, it also has a different name. And depending on where the fibroids are located, it can cause certain symptoms in the patient.
What are those symptoms? Because I'm sure it's not the same for all women.
Absolutely, yeah.
What are they?
So the thing to know is that a lot of women actually move around with fibroids without knowing that they have fibroids. So they're only an issue if they cause symptoms. And so the way that I think of fibroids is that they mainly cause 3 symptoms. The first one is issues with your menstruation. So it could be heavy or painful menstrual cycles. The second one is what we refer to as bowel symptoms, and I'll dig deeper into that at some point. And then the last one is issues with pregnancies or anything to do with your reproductive outcomes.
We'll get to that in a moment, but is there an age group? I mean, do you find where it's women over a certain age, or is it just, overall, depending on, where they're at in that cycle?
So that's a great question. So it's really mostly women that are in the reproductive age.
Okay.
And most studies have shown that the prevalence of fibroids tends to increase as you get older in your reproductive ages. So mostly women tend to present around their mid-30s with fibroids.
Now, when someone comes to see you, walk us through your process in meeting a patient for the first time.
So a patient coming in with symptoms suspicious of fibroids?
Yes.
Yeah. So for me, because I'm a specialist, by the time that patients come to me, they already have a diagnosis of fibroids. So the first thing that I do when I meet a patient is to start from scratch. So I get a history, try to tease out the symptoms that they have with the fibroids. So I'll get a very detailed menstrual cycle history, look into other symptoms that they might have with fibroids. And then after that, I do an exam to see how big are the fibroids, where they're affecting the patient. And then after we've had the history and the physical, again, I'm like starting from scratch. Even with patients that have had fibroids for 10, 20 years, I will pull up images and explain to them, this is what the fibroids are, this is why you're having the symptoms, and then we'll go to the treatment options and then come up with the plan together with the patient.
So what type of doctor are they seeing before you see them that they've already been diagnosed with the fibroids? So
mostly it's their primary care physician,
okay.
And sometimes their general OBGYNs. And so key things to be watching out for patients that have especially heavy menstrual cycles or abdominal pain. Those are kind of the symptoms that the primary care providers are watching out for.
Have you found where, they're not seen on, let's say, an X-ray or a CAT scan, but they're still having this pain and they're still having these problems? Mm-hmm. What then? What's the next step to be able to find out what is actually going on? That if they have the fibroids, are they always showing up
Yeah. So the good thing with fibroids is that we have a really good imaging to be able to identify fibroids.
Okay.
So getting a pelvic ultrasound, you can be able to see that on a pelvic ultrasound, on a CAT scan, or even an MRI. Different from last time when I was talking about endometriosis, where you can't see that on imaging. So I think that's the great thing about fibroids, is that you can be able to identify them on imaging.
When someone comes to you and they're not understanding the whole picture, and right away people do think of cancer. Do you find that there is a genetic, that it's passed on? Is this something that women have to be concerned about, like the BRCA2 gene? I have that, so I know the lineage that it's come from. Is this the same thing?
So you've opened up a whole can of worms.
Of course.
So there is a genetic component to fibroids, but we just haven't identified what the gene is.
Okay.
But one thing that I've noticed is that if you have a patient with fibroids, when you ask them about their family history, it's not surprising that the mother had fibroids, the sister had fibroids, or sometimes patients just say that, oh, my mom had a uterus taken out because she had been heavy bleeding, and for the most part it was probably because of fibroids. In terms of the exact gene, people are still trying to figure out what exactly is the genetic component to it. But for most of the part, if someone has fibroids, someone in the family has also had fibroids in the past. A good example is me. My mom had fibroids, and then I also had fibroids at one point. So there is a genetic component to it.
Does a fibroid have to be removed?
Not necessarily. So I think one of the things I always reassure patients is that for the most part, fibroids are not cancerous, and if they don't cause you any symptoms, then you don't need to do anything about them. So if sometimes I've had patients that someone found out they had a tiny fibroid, they're not having any symptoms, and then at that point in time, we just decide to watch and not do anything. So if someone is not having symptoms, we don't need to do anything about them.
Do you find where there's a misdiagnosis when it comes to where they've gone to different doctors and there's nothing that's been shown up, but then they just say, okay, this is what it is? Is there like a period of time where you're just unknown and things can get worse? Or how would they know, what they need to look for other than the two that you mentioned? But then sometimes we get a diagnosis and it's not even close.
That's true.
Especially with women.
Absolutely. So I would say that for the most part, it's really hard to miss the diagnosis of fibroids on imaging. So I think the key thing that patients need to be advocating, if you really have like heavy menstrual cycles or painful menstrual cycles, or sometimes I've had women that say that I've been trying to lose weight, but I just can't seem to get rid of this belly fat just because it doesn't seem to want to go down. Or some people are like, oh, I keep on pressing my belly and I feel like there's something inside. So I would say for those patients that maybe they go and talk to the primary care provider and people just seem to downplay their symptoms, they should really try to advocate to see if they can get imaging done. Because for the most part, once you have imaging done, you can be able to identify fibroids on that.
Now, having fibroids and being diagnosed with them, does it prevent pregnancy? Does it cause a problem with pregnancy or fertility?
So that's kind of like, I like your questions. So it's like an ongoing debate. So the one thing I tell patients, like if they have fibroids, the only way you can tell if you won't be able to get pregnant is if you try to get pregnant. So you're still able to get pregnant even if you have fibroids inside your uterus. The only way to know if they're causing issues with your pregnancy is if you've tried to get pregnant and you have things like miscarriages, or it's getting hard for you to get pregnant. But so not necessarily that they might make it hard for you to pregnant, but they might not necessarily prevent you from getting pregnant.
Wow. I wouldn't have thought something like that would, well, I guess where it is and all
the way
the,
it is,
yes,
yeah.
Absolutely. Now, when a young woman, I mean, you're talking with the years, you're talking anywhere from the 20s or your teens.
I have actually not come across teens with fibroids. Mostly tends to be early 30s, except for African Americans. They tend to present earlier in the reproductive ages, mostly like in the late 20s with fibroids, but not so much in the teens, which tells you that this is mostly a problem with the reproductive ages.
What causes it?
We don't know. We don't know. Another great question. I feel like there's a lot of research that still needs to be done on fibroids, and because right now most of the focus is on treatment and managing of fibroids. If we're able to figure out what causes fibroids, then we might be able to prevent people from forming fibroids in the future. But there's been a lot of speculation in terms of what might be the causes of fibroids. And right now, the main thing we just have are risk factors. One of the risk factors is age. So as you grow older, you're more likely to have fibroids. The other one is race. So being, again, like I mentioned, African Americans have a 2 to 3 times fold of having fibroids, and they tend to present earlier with more severe symptoms than other races. Some people have speculated that a higher BMI might put you at risk for fibroids. And then also things like diet.
I was just going to ask you, dietary.
Again, all of these were like association studies. There's not really strong evidence, but it's also something that I tell my patients it's something worth looking into because you don't really lose much from doing these dietary changes. So people have speculated that eating red meat, like lots of red meat, smoking, drinking alcohol, vitamin A and vitamin D deficiency might put you at risk for forming fibroids, which are all good things that you should probably make in your like lifestyle. Yeah.
So how do you approach that to someone coming in that really is very skeptical of either the invasive or how would you approach them going, well, I'd like to really try natural remedies first?
So it honestly depends on the symptoms that they're having. So if they're having mostly like issues with heavy bleeding, so the first thing I'd recommend is to try hormonal methods. In terms of natural remedies, I would tell the patient that there's not much evidence on that. They're more than welcome to try that, but there's not much evidence in trying those natural remedies.
Do you find that there's becoming more research on this, or is it kind of just on the wayside, let's concentrate on the treatment and surgery and that sort of thing?
I feel like it's still on the wayside, mostly because I think treatment and focusing on like the surgeries, like that obviously like generates revenue for most things compared to prevention. But this is why it's great. This is Fibroid Awareness Month. Hopefully, if the researchers out there, that are focused on fibroids, maybe they might want to continue looking more into what are some of the causes for fibroids. But it's been one of those things that's been sidelined.
That's it. If you find out what the cause is, you don't need these other things
There's other
here.
things, yeah.
And it's a lot easier to catch. And I think for women, you know, when you're in pain, you're not really in a good mood either.
Absolutely.
So I mean, overall, your physical, your mental state, you know, especially when you're in pain, and you don't know what it is.
Yeah.
And you mentioned race. Have they found out what could be causing one race versus the other when we're all women with the same body parts, I should say?
So I think one of the things that people have suggested is that African American women tend to reach their menstrual cycles at an earlier age.
Okay.
And so that means they get exposed to the hormones like estrogen and progesterone, which have also been thought to contribute to the formation of fibroids. So that's one reason why African Americans might be affected more than other races. And some people think maybe lifestyles and like certain exposures that they might get.
You know, and you speak, you know, those in the productive years, a lot of, I find where a lot of teenagers, or when they hit a certain age earlier going into puberty, than I can remember years ago. Is there a reason for that? Is it dietary? Is it, you know, because if you start at an earlier age, whether they say, eating fatty foods, greasy, whatever the fact may be, that would start the cycle a lot earlier.
Yeah. And so that would probably mean that you're getting exposed more to
Right.
your reproductive hormones and then more likely to form the fibroids. Again, it's just a speculation, but I think when I've looked at some of the studies, that's the thing that actually makes sense to me as why the African Americans might be at more risk for fibroids.
So when it gets to the point where they've been diagnosed, they've come to see you, the decision making, what do you offer them in the sense of types of treatments? What is out there? Where do you start?
So the great thing with fibroids is that we have so many different options. So the one thing I tell patients is that we have so many different options, which is a great thing. So it might be a matter of trial and error and up to the point that you find something that really works for you. So if I have a patient that's mostly just having heavy bleeding, and sometimes people end up having iron deficiency anemia because of the heavy bleeding, we might try to focus on hormonal methods to be able to control the amount of bleeding that they have. And then if I have patients that have really huge fibroids, unfortunately the medication doesn't shrink the fibroids.
Right.
And then we look into other options. And so for those options, they can look into, so one of the options is whereby it's called a uterine artery embolization. So that's done by radiology, whereby they block blood supply to the uterus, and then as a matter of that shrinks the fibroids and reduces the amount of bleeding. So that's one option that I talk to them about. And then I talk to them about, so another thing would depend on whether patients want to keep their uterus and whether they're done with childbearing. And then after that, we could talk about taking out the fibroids or just taking out the uterus altogether.
That's got to be really drastic, though, when they want to take out the uterus at that point.
Yeah. So that's kind of like the last option. And so for me, because our practice is specialist practice, most of the patients we end up seeing are people that have already tried most of these things, and they're at that last point where they're like, I'm done, just take out the fibroids or just take out the uterus.
That's a heavy decision that a woman
That's a heavy decision to make,
needs to make, depending on the age.
Yeah.
What do you, not only as a doctor, but as a woman, what advice do you give to young women and women out there that are facing, possibilities of having the fibroids, having not going through the process of a diagnosis?
So I would say we've come a long way in terms of taking care of fibroids. So like I mentioned, I love talking about fibroids, and one of the things I've looked at is into the history of fibroids and how we got where we are right now. For young women that have fibroids, I would not, one thing I would say to them is that having fibroids does not necessarily mean that you're going to end up losing your uterus. There are ways that we can be able to take care of your fibroids so that you can be able to have kids later on, if that's what you're thinking about. And so there are many options for that. So I would tell them that, yes, you have fibroids. It's not a death situation. We have ways of taking care of the fibroids if that's what you just want us to focus on.
What's the overlook? What's the outlook for fibroids out there for the women that you feel is important enough for them to know?
So unlike, again, I'm going to mention the endometriosis, I feel like fibroids is one of those things that there is a cure for it. So if you just wanted to focus on us taking out the fibroids, we can be able to do that. If you wanted us to focus on taking out the uterus, we can be able to do that. So it's one of the few conditions that I feel actually has a cure, and the prognosis actually looks good for people with fibroids.
Now, if someone just, there are women out there that just go, you know what? I'm going to ignore it. I'm just not going there. What advice do you give them?
So I guess there are two things. If they're not having any symptoms, that's fine. They can just watch the fibroids. But if they're having symptoms, I would say just come to us, come for a visit, just to talk and discuss the options and see if there are other things that you can be able to do for that. Because honestly, I don't think it's okay for you to be having painful periods or to be having heavy menstrual cycles. Another thing that fibroids can cause is that, so sitting behind the uterus is the bowel. And then if you have fibroids pushing on the bowel, some people can have constipation. And then sitting on top of the uterus is the bladder. And then if you have fibroids that push on that, some people can have issues with urination. So all those lifestyle things, it's not natural for you to have that. Or if you have like really big fibroids, some people just have continuous pelvic pain, and that's not like a nice thing to live with. And some people can even have pain with sex. So if you're having symptoms, I think just coming for a visit to talk about options, and it's a good thing. I've had patients that they were having pain with fibroids, and then we do surgery, and then I call them like 2 or 3 days later, they'll actually say that the pain that they were having before surgery is worse than the pain that they have after surgery, which really tells you that you should not continue going on with like those symptoms of fibroids.
You know, there are women out there, and I would be one years ago, and be afraid to find out. And, you know, always think the worst, not that there's a cure, as you just said. Early detection is the key. If they wait too long, does the mass grow? Does it interfere? Like you said, the bowel, the bladder. I didn't even think of that. But where does that go?
So it's a hard question to answer. And the reason why I say that is that we haven't come up with a good way to predict how much your fibroids will grow per year. So some people have the fibroids stable for like until they reach menopause. And some people will start off with a tiny fibroid, and then within 3-4 years, it's like 10-20 centimeters. So it's really hard to know how quickly the fibroids will grow. But the key thing is to really once you know that you have the diagnosis of fibroids and they're not having symptoms, keep a close eye on your symptoms and see if anything changes with time. Because sometimes if you start noticing symptoms, the longer you wait, the more kind of slightly complicated it will get to take care of the fibroids later on.
Now, we mentioned early on that there were different types of fibroids, but they're all contained in that area? And what are the different types?
So if you think of this as being the uterus, and then the inner lining of the uterus is called the endometrium. And so the muscle layer of the uterus is where the fibroids grow. So if you look at the muscle layer, the part that's nearest to the inner lining of the uterus, the fibroids that grow closer to that lining are called submucosal fibroids. These tend to cause you to have heavy bleeding with your cycles, and these might also affect your pregnancy outcomes. And then the second one are mostly just in the muscle layer of the uterus. Those we call them intramural fibroids, and then they can cause you to have like the pelvic pain, bowel symptoms, and sometimes might even cause you to have symptoms with bleeding. And then the last one are the fibroids that grow on the outside of the uterus. Those we refer to them as subserosal fibroids. These don't so much cause you symptoms with like bleeding because they're on the outside of the uterus.
Right.
But it mostly depends on how big they are and where they are located. So if they're, again, pushing on things like bowel or your bladder, those are some of the symptoms you can have from that.
You know, when you're talking and describing that, it's so close to some of the symptoms with endometriosis.
Exactly. Yeah.
And it's like the two, because you basically have the same type of testing, correct?
Exactly.
Okay. And they can determine from that which endometriosis or fibroids that you may have.
So it brings me back to the question you asked me before, saying that when you have a patient that has heavy bleeding or painful cycles, and then they get an ultrasound that doesn't show anything, like what should they do next? I think for those patients, the next thing to be thinking about is that could this be endometriosis? And that's because endometriosis doesn't really show on most of the imaging we have, but fibroids tend to show on the imaging.
Okay.
Yeah. But they sometimes can have the same symptoms.
Yeah, because as you were describing it, and in the past, when you've been here at the studio and talking about endometriosis, it seems to be just right in line with the other, and you can get, geez, one or the other, but at least we know that fibroids can be detected by one of the tests.
And then sometimes you can have both. You can have a patient that has both fibroids and endometriosis. Yeah.
Oh, that's really
yeah. But
double-sided sword.
But we can take care of it.
There you go.
Yeah.
The prognosis is good on either one, and there's a cure.
Yeah. And so the key thing is advocating for yourself, like, and doing your research, trying to see who focuses on those things. Like, you can talk to your primary care doctor, and you feel like you're not heard, look for someone else. Like, keep on talk to other people. There are like different platforms out there that people could look and see what else might be going on.
Now, how do they contact you?
So we will post our address on the website. So I'm located at Women and Infants Hospital. Right now our office is at 2 Dudley Street, but in a few months we'll be moving to 90 Plain Street. But we'll have all that information on the screen.
Sounds great. You know, it's something because women always seem to put their health in the back seat.
Absolutely.
And they're the ones, as you said, should advocate for themselves because nobody else is going to.
No, yeah.
And then you leave things go and they get much worse. And that really doesn't help with other parts of the body or the mental state either.
Absolutely.
So we need to have women out there advocate for yourself and listen to all the symptoms that you may have. But you got to understand there's a cure and there's a great prognosis.
Absolutely.
Outlook.
Absolutely.
Is there anything out there that you'd like to let them know further about fibroids or endometriosis?
I would say, I think the biggest thing is that, like, kind of like saying, repeating everything that you just said. If you feel like there's something wrong with, like, just like your menstrual history or like any symptoms that you're having, I think it's worth it for you to dig deeper. Anything that affects your functioning, your quality of life, anything that's potentially even affecting you being able to get a promotion at work, be it like the heavy periods, the painful periods, or anything, I think it's just something worth looking into. And if it is fibroids, just because there's the word tumor, most of the time it's not cancer.
That's scary.
Yeah, just the word tumor,
Yeah.
but realizing the word tumor does not necessarily mean that it's cancer.
The thing is, we've been brought up to, you know, when we've had our menstrual, you know, that goes along with it. The pain goes along with it.
Yeah.
You need to just kind of get up and move on.
Absolutely.
Or you need to walk more, or drink water more, or whatever.
The water one, I've been told so many times, if you're having cramps, drink lots of water. But no, it's not necessarily because of the dehydration. And a lot of it can also be cultural, right? So you're told that's the way to go. Like, you're woman enough if you're having heavy and painful periods. But no, that's not right.
Get it checked out.
Get it checked out, yeah.
Well, I want to thank you so much for coming back to our studio
thank you
and
for
letting
having
us
me.
know. And of course, this month is Fibroid Month.
Absolutely. Thank you so much for having me again.
Thank you, and we're looking forward to you coming back.
Oh, thank you.
And to the women out there, you're the advocate for yourself. Just make sure you pay attention to your body, and if you need to give her a call, check at the end of our show, and you'll be able to find the website and phone number contact. Thank you for watching A Woman's Outlook.